Welcome back, everyone, to Quality, where we're exploring quality in emergency care. I'm your host, Arjun Venkatesh. And today we've got a wonderful set of guests talking about a topic that has, in some ways, you could say what's old is new, but also what's new is newer. We've got Kate Hawk joining us here. She's an emergency physician at Yale University and a co-lead of the Equal Substance Use Disorder Initiative. And we've also got Jeanmarie Perrone, who's an emergency physician and addiction medicine specialist at the University of Pennsylvania. Both of them are on the cutting edge of what's going on in treating substance use disorders in the ED. And today we're really going to focus in on and talk about alcohol use disorder in the emergency department and treating it, and how we start to think about this. I'm going to kick us off with what is, I think, one of the more sort of challenging concepts around this, which has been that it's been a big shift in emergency medicine over the last couple of years. Just treating opioid use disorder. And that feels different because we see people with a life-threatening overdose. And now we've got increasing evidence about what we can do to initiate and get them on treatment versus alcohol use disorder sort of feels like it's been around for a long time. There hasn't been a day where people haven't worked in the emergency department where we see people with alcohol intoxication or withdrawal. And so, Jeanmarie, Kate, where's all the attention coming from now? How's this sort of taking off recently?
I can add just my thoughts here first. I think we were lulled into a lot of complacency in emergency medicine about kind of the background of alcohol use for many years earlier in my training, and even up until recent years, where patients would come in with profound alcohol intoxication, often very frequently. We would know these patients pretty well, but we didn't really feel like we had a lot to offer. And then with the paradigm shift of really starting opioid use disorder treatment from the emergency department, I think we really learned how to elevate this problem and these problems of kind of multiple levels of challenges for patients that we can address in some ways. And not to say that this is our problem, but this is our opportunity to treat patients and offer patients in probably the only time they access healthcare in the emergency department. And then maybe the other big reason is I think we all know that, being at home during COVID, alcohol use increased in many populations, and now alcohol morbidity and mortality has gone up by about 20%. And some of those groups with the faster rising rates of problems are women. And so, thinking of family members and friends who might be at risk, I think we really need to think about this, not just in the emergency department, but across all of our domains that we are people and advocates in.
I think one of the other things that shifted is that it wasn't always that we did a good job of understanding that addiction or substance use disorders were treatable diseases. As clinicians, that's not something that we were necessarily taught if you went to medical school in the 70s, 80s, or 90s. And I feel like there's been sort of a re-emergence to understanding that, by and large, these are treatable diseases. And while it might not just be that the domain of one particular type of clinician, as generalists and emergentologists, we, span expertise in a large variety of fields. And this is certainly one where, as Jeanmarie pointed out, these are not, we may be the only people who see these folks in the ED. And so it's an opportunity to intervene that is consistent with our goals of being clinicians.
So I don't want to be negative and I don't want to be cynical, but it does build off of there a little bit, which is, is there something special about the emergency department, something special about our skill set? Is there something about emergency physicians that sets us up to do this well? Or are we just putting another Band-Aid on the healthcare system and just, treating alcohol use disorder because nobody else will? I think one of the things people probably are going to find a little frustrating in this, just as, people often report for opioid use disorder, is that it's really hard to find follow-up. And so if nobody's willing to help, and if nobody else is willing to help take care of patients with an alcohol use disorder, then sort of why should I? And what do you tell those folks?
That's both tough and easy, right? So I remember asking an oncologist once, how can you take care of cancer patients? That's so depressing. And he said, if I wasn't taking care of cancer patients, there'd still be cancer. And, I think we have to offer people treatment because we see these people and we've learned to be compassionate because their problems are so multidimensional. It might be housing, it might be childhood trauma, it might be a very different childhood and young adulthood than we had. or it might be very similar and they, have the genetic predisposition to alcohol use disorder. So there's a lot of different reasons why I think substance use occurs. I think it's kind of interesting when you look at, travel in other countries and look at substance use problems. In actuality, there is a lot more substance use in our country, but there's a lot of alcohol use. There's essentially more or comparable alcohol use in other countries relative to our big opioid problem. So, alcohol use is ubiquitous in the world, and finding low barrier treatment strategies that are effective, I think we're just scratching the surface on that now.
All right, wonderful. So Jeanmarie, can you tell us a little bit more about when we talk about treatment for alcohol use disorder, what kind of medications are we talking about?
So some of the initiatives that we're thinking about, first of all, one of the differences between opioid use disorder, OUD, and alcohol use disorder, AUD, is that, we felt in our emergency department that we needed to do a little more screening for opioid use disorder. And then when I think about alcohol use, our patients are a little bit more obvious. And so recognizing that you're having, a conversation with a patient with alcohol use, the conversation can be a little bit different because it's already starting with something that's out in the open, maybe more so than opioid use sometimes, I guess. But, talking to the patients about when they, what triggers they have for drinking, what periods. A lot of patients have had long periods of successful abstinence. And so talking to them about how they were able to facilitate that, how they could potentially get back there, with a little bit of support from a health system. And then thinking about the medications, I am always shocked. I've been doing this for maybe 2 years now, offering patients medication. And when you ask them, have you ever been, has anyone ever talked to you about your alcohol use? Has anyone ever offered you a medication to help you, decrease your drinking? And almost uniformly, everyone says no. So even in people who have been in treatment, who have successfully, come through and had periods of recovery, very few of them have ever been offered medications, which makes it super low-hanging fruit because, I think a lot of people come to the hospital looking for antibiotics, looking for medications, looking for quick fixes. We can turn this into something that patients are excited about, that offers them an opportunity to start a medication that can help them, mitigate this problem. So the medication I primarily offer people is naltrexone. It's a full opioid antagonist, but in this setting, it's really working to block some of the euphoria and reinforcement associated with alcohol use. And so it's a pretty simple mechanism to explain to colleagues and patients, and also is a little easier to initiate than buprenorphine in terms of you don't have to wait for withdrawal. The patient can be actively drinking. They can continue to take it when they're actively drinking. And the dose titration is pretty simple. We start at 25 milligrams, maybe for 1 or 2 days. If that's well tolerated, they can go up to a therapeutic dose of 50 milligrams. So there's not any of the microdosing, macrodosing, lengthy initiation, have to be in withdrawal, similar to buprenorphine. It's much cleaner and simpler. And I think that allows for easier onboarding of colleagues to begin offering this medication. Now, I know, Kate, that you have also done some work, also including gabapentin in adding to treatment in certain settings. Maybe you could tell me when you consider prescribing both.
Sure. So, much like you, we started offering naltrexone a couple of years ago, and I agree completely. It is remarkable how low-hanging the fruit is, and that many people are very interested in a medication that can help with craving, but have never, ever been offered it. And so this is not about sort of doing elaborate, detailed interventions to convince people to take medications. It is simply, actually, I had a patient last week who was literally signed out to me as metabolized to freedom, who came in as a fall with an injury, got CT scans, had an alcohol level well above 400, and literally the morning sign out was, make sure they can walk, make sure they go. We talked about this a little bit, but this was somebody who, when I went to reevaluate them, offered treatment and said, absolutely, I can't miss work. I can't lose my job. I can't miss, I can't I have kids at home I have to take care of. And this is somebody who, may have been better served inpatient because he probably was going to have some withdrawal symptoms based on his alcohol level. But this is somebody for whom I think gabapentin was actually an amazing option. We did both gabapentin and naltrexone. And the rationale behind gabapentin is that it provides an opportunity to help with some of the mild to moderate ambulatory withdrawal symptoms. It is not sort of the gold standard for folks that this is not for, the folks that you think might wind up in a drip on the ICU. It's really a placement for chlordiazepoxide or another benzodiazepine for ambulatory withdrawal. And so that's who I think about gabapentin for, but I agree completely. Naltrexone is really, a slam dunk if you can get, if you have folks that are really hungry for something to help them reduce their alcohol use. It makes perfect sense that we should just make it as easy as possible to provide that.
As I hear you guys give these examples, the story is so true. From a clinical example perspective, the population that has an alcohol use disorder is probably one of those populations that's at very high risk of being subject to an ED handoff between shifts. Right? By nature, it's a patient population that's going to come in on one person's shift and leave on somebody else's. And in our world, our EDs are crowded. We're trying to minimize length of stay, and we know handoffs are risky. And so we tend to try to simplify them as much as possible. So that handoff of sober and discharge, metabolized to freedom, I put their discharge papers in for you. Just wait as soon as they can walk, just click print. Right? That's pretty common handoff. The problem with all that, though, is that first person isn't really in a position to ask that question, identify whether or not that person could get treatment. So help me, if I'm the doc getting sign out on these patients, what's the efficient script? How do I get to it in one or two questions, figure out if this is somebody who is where there's that low-hanging fruit opportunity to treat? And if they say yes, what's sort of my go-to drug dose duration to sort of get things kicked off?
So I think one opportunity that you mentioned there is true. These patients are handed off. So maybe we should frame the opportunity as the person who receives them, because in reality, the other person, like you said, didn't have a lot of opportunity to chat with them. But these patients are often handed off in the morning. We're a little less busy in the morning. It's part of kind of the overnight cleanup. They're somewhat straightforward. If the patient's, awake and alert and ready to go, that might be the perfect time to talk about, do you have a primary care doctor? Do you, seek, have regular medical care? What do you think about, this problem and the fact that you ended up in the emergency department? I think by any categorization, somebody who has an ED visit for alcohol use has risky drinking or alcohol use disorder almost by definition. So they're probably all candidates. An important exception, and one that's sometimes overlooked in our era of excessive opioid use disorder, is that a lot of patients do take both alcohol and opioids, or they're prescribed opioids for other reasons. So really have to be clear that we don't want to be prescribing naltrexone to people who occasionally or sometimes or commonly use opioids. So that's probably the biggest issue and safety issue with this medication. But I would say, an eager intern or second year resident who's going to be out there doing the cleanup and discharge, they're the ones who are excited to have these conversations and to be ready to prescribe. So one thing that we just started in our emergency department is a nudge or a provider banner that's going to allow team caring for the patient to be reminded that they had an elevated alcohol level, and when you go to discharge them or admit them, depending on what it's for, you can consider starting naltrexone. So we're trying this. We had a lot of success with this with opioid use disorder and initiating buprenorphine, but sometimes it's just really helpful to remind our clinicians that this is an opportunity at discharge to start this medication, or at least have this conversation.
Yeah, and this is, I would also put in a little plug for the brief negotiated interview, which, can be more, it seems like can seem like a big sort of unwieldy motivational interviewing technique, but honestly, it can really be done in like 3 to 5 minutes, or even faster if you have somebody who is ready and interested, which is who we're really looking for. Where you introduce yourself, you ask if they're willing to talk about their problem with, alcohol or opioids, and then ask them if they, have any connection between their visit and their alcohol use. You can also ask whether they've ever been, in treatment before, whether they, have any interest in seeing treatment. And I mean, honestly, people will be like, yes, I was in treatment, I want to go back. And so really the next steps are to help identify a plan. Again, this is not about spending a long time trying to convince people to do something they don't want to do. It's really about, there are medicines to help you when and if you're ready. You can talk to your primary care doctor or us, in the emergency department when you're ready. And then the other thing I know Jeanmarie very clearly said you don't give naltrexone to people with opioid use disorder. That is the one absolute contraindication. So just want to make sure everybody sees that really loud. And that's actually written into our, when you go to prescribe naltrexone in our ED, it's actually like a safety stop. Like, did you talk to them about opioid use? But other than that, people do very well with the medicine.
Yeah, and I think the important thing is you have to ask them, right? You got to talk to the patient about that. I think there's what you don't want to be doing is it's an absolute contraindication, but it's also one where you absolutely talk to the patient about it, don't make a desktop diagnosis or a desktop contraindication. That's how, we end up making assumptions and people don't get the treatment they should get. Tell me, there's a ton, if I'm I'm trying to think about this. I'm a medical director out there. We're trying to decide how to approach this, or I'm an ED doc out there trying to figure out whether I want to get, start treating more people. A lot of places have gotten their treatment programs for opioid use disorder up and going, not alone, but with a lot of help, be it peer recovery specialist, social worker, working with addiction medicine, psychiatry. And so there's this, real idea out there that you can do it and it's better if you've got a lot of other support services. Some states fund people, right, in California to have a lot of help in the ED for opioid use disorder. How much of that is similar or different in this case when we're treating alcohol use disorder? Do we need all those pieces just as much? What can we do without? A lot of our EDs in the emergency quality network don't have access to a lot of these kinds of resources. And so a lot of this is trying to figure out what's realistic for the average ED out there.
I think that it's a little bit different and easier really than opioid use treatment. Our patients with opioid use disorder pretty much are leaving the department with a strong craving and desire to use immediately. Alcohol is a little bit different. People achieve periods of abstinence more readily, especially if they have more of a binge drinking problem. So they'll have episodes of, abstinence or less intoxication in between binge drinking episodes. So it's not quite as chaotic as opioid use disorder. So some of that care navigation that we try to provide with peers is somewhat less necessary. I think follow-up is still really important. Obviously, we're going to start them on a prescription that ideally would be continued by a primary care doctor. So that is something that we'd want to tie a little bow on the handoff. But I think the need for peers in this setting, it would be amplified and wonderful, but probably very unnecessary compared to the opioid use navigation that has to occur. The other population that I think is super helpful and really, when we started first doing buprenorphine from the emergency department, we didn't have all those pieces in place. And so we tried to just say, use buprenorphine to help patients with opioid withdrawal. So just give it for opioid withdrawal, just, have a low threshold for giving it to patients who, may be trying it for the first time and are interested in getting into treatment. And we had the X-ray where we had all these other complications to it. But similarly, people who have binge drinking, take, for example, a college student who's been in your ER. I know you guys work in the ER, a college student who's coming to your ER maybe twice in one semester. That's a patient. It was a great conversation because there are opportunities and evidence now to suggest that using naltrexone PRN before a big event like a frat party or something where you've been out of control is really a new opportunity for a patient to take 20 naltrexone prescription from the emergency department and try it 3 times over the next couple of months and see whether or not it helps and whether or not they need to go back somewhere to get a refill. So we want the handoff to happen, but actually there might be an opportunity for people to try it even off of one prescription.
And the other thing that I would add is that, I think that the waiver was such a barrier as far as handing people off with opioid use disorder back to their primary care doctors. Whereas I think that's not nearly as much the case for at least people who do have primary care clinicians, because it's not, they're less scared to prescribe naltrexone. It's not a controlled substance. There's not the waiver. I think that Ideally, it would be nice to connect some of these folks, particularly with severe alcohol use disorders, to a specialist. But, the reality is we know that there are not enough addiction specialists in this country to treat everyone with severe use disorders. And so, I think the more important thing is that, it's better to hook them in, give them a script, have that conversation and hook them in with their primary care doctor. It's certainly much, much better than nothing, which is, what a lot of us were doing before.
I want to go back to this college student idea, because I think it is one I have not heard before. I am sure people heard Jeanmarie say that and were thinking, wait a second, is that like pill in a pocket for alcohol use disorder? And then immediately where did my head go from there is, I have to imagine the usual sort of harm reduction police that are afraid that we're going to normalize deviance and that we're going to promote increased alcohol use if you can just go take a med for it whenever you need. What do you say to those kinds of people?
Well, I think it's a little different than maybe promoting deviance, because you can take it while you're drinking. So it's not really, it's really just harm reduction. It's helping people drink less. So they're not going to, I don't see them, taking 10 naltrexones and then not drinking and then taking no naltrexone and drinking too much. I think it's a little bit different than kind of going overboard. But I think, if you had to account for the, ratio of people that you could help with that prescription, I think it would, solidly land on the positive side. I think the idea of, having a younger person in those, big periods of excessive drinking have an opportunity to start to rein it in. If you've had a ED visit for alcohol use, and I said this before, you're at great risk for having a lifetime alcohol problem, even when that occurs in college. So, getting this under control in a time frame where their brains are still young and they can, really experiment, if you will, with control, I think is kind of an interesting opportunity. I don't think all the data is there, but in certain populations at high risk, this has been used. And I think it's something that we could really build on from our emergency department populations.
And it's interesting here because we're so trained to think about the acute problem that we think about often acute outcomes, right? We measure 72-hour revisits to our EDs. At most, we'll look at what happens out of the 10 or 30 days. Is there a 30-day readmission after an ED visit? We forget our pediatric EM colleagues often take this very long-term view of treatment when they care for a kid in ED, really thinking about how that visit may or may not send them on a different health trajectory long-term. And there's probably a lot of that really applies particularly to the younger patients we take care of in our adult EDs. You guys are experts in this. So, the vast majority of EDs out there aren't going to have two people in place. They're definitely not going to have somebody who's bored in addiction medicine or a researcher in substance use disorders, things like that. But more importantly than that, they may not have sort of even a local champion yet. And so how do, we have a lot of EDs, several hundreds in the Equal network that are trying to build up programs around this. They're interested. They're trying to get interested for the first time. How important is it that you have to have one super passionate champion in order for these kinds of things to take off? Or is there a way that they can just sort of work their way into practice without that? Because we do a million things in emergency medicine. We don't have a champion for everything. I don't have an anaphylaxis champion in our ED, yet we do a pretty good job taking care of patients with anaphylaxis. And so how does that translate over to this?
I had this really wonderful email from a colleague at a community hospital just like 2 weeks ago. And she said she had just read Kate's recent article about naltrexone in the emergency department for alcohol use disorder. And she wanted to know if we were doing it and how. And she was really excited about it because she thought it would be, her team would be excited about, offering this to patients. So I think publishing in the literature, things like this Equal network, and, getting the word out that this is feasible. I mean, in my, super evidence-based, academic medical center, and probably yours, naltrexone is barely used. I can't understand. I mean, I graduated from medical school a long time ago, but why aren't the people who graduated 5 or 7 years ago who are on internal medicine services not using it? I mean, we actually just pulled our naltrexone data. It was prescribed 6 times in the emergency department in the past 6 months. 4 of them from people, my addiction medicine colleagues and me. And, internal medicine, the only people who are doing it are outpatient psychiatrists, like 300 prescriptions in outpatient psychiatry. So nobody's doing it. Nobody's doing it from the hospital. I don't know why. I don't know where that evidence gap is coming from, or why it's so persistent. Because this is not a scary drug, and this is a super common problem. So that's a bit of a mystery to me. But in the emergency medicine domain, I can see why it hasn't occurred yet. But it's just a perfect opportunity to get more evidence out there, socialize this within our ED literature, and have a ASAP session on it. Get it out there in all the different ways that people learn, and I think they'll come asking for more information from the community or from urban settings.
Jeanmarie, thank you for sharing that. That made my day, because I have to say this is really why we write, right? Is to help get things out to the community. And then I think the other thing, and I mean, Arjun, clearly you are someone who understands this very clearly and has hit the nail on the head, is, you talk about this in the frame of quality. Like this is quality care. This is what we should be doing to provide quality care to our patients. And it's not necessarily about one person's pet project or having a local champion for anaphylaxis or for antibiotic stewardship, although those things can happen. I think that, part of how you implement this in places where people are like, I don't know, like we could do this, like that should be enough. If you provide people with a protocol and like sort of clear instructions for how to integrate that into their emergency department, which we have tried very hard to make available, on the eQual website certainly for treating alcohol use disorder and opioid use disorder. And so the idea is that you don't have to reinvent the wheel. If you are a place that doesn't have someone who wants to reinvent the wheel, you can take something that's been sort of done or worked out in another, 10 or dozen EDs or hundreds of EDs and say, oh, like we'll take this off the shelf and this is the protocol we'll use, or the pathway. I don't know how many of you are using Epic Pathways, but we're like, this is what we do and this is how you do it. And this is one of the things we learned for opioid use disorders. Like if you just make a protocol and say, I have leadership support of this protocol, like it gets done. So, I mean, I think that's really, there are a couple of key things to get it up and moving in your ED.
Yeah, you've done a bunch of work as well on stigma. And just tell me, how much is that getting in the way of us here, right? It's like Jeanmarie said, we've had the medicine around for ages. The patient population's been around for ages. Is it sort of conscious, unconscious bias? Is there so much stigma that we sort of just think that, oh man, like I'm just going to be a drop in the bucket. I'm not going to be the person that can really turn the ship here. And is that what's keeping people from sort of really engaging and taking this on?
Well, I think, so I have a comment, and then I know Jeanmarie has also spent a lot of time thinking about stigma. So, I mean, I think that part of how we are able to do our job day in and day out is that we don't absorb sort of the traumatizing things that we see and experience every day. And so I think part of what we think of is we don't necessarily think of alcohol use disorder as a traumatizing disease every time we encounter someone who's intoxicated. And so I think it's around shifting that perspective a little bit. We certainly know that these medications for alcohol use disorder do work to help reduce return to drinking and days of heavy drinking. And I think a lot of it is really just around educating folks who did not get this education in medical school or residency, and really, helping people identify how rewarding it can be to help someone change their trajectory, which I think is really what we're trying to ask people to do.
Yeah, I also think that it's slightly easier, I mean, in many ways than opioid use disorder, because it is a little normalized, right? Alcohol use is, socially acceptable. Even excess alcohol use is somewhat socially acceptable. So when you're talking to patients, I think as a provider, you don't have to struggle as much with, do I have all the right answers? Because it comes, a little bit more easily in just kind of stuff that we know. So, for Kate's motivational interviewing, I mean, we know a lot of these patients come in with trauma associated from a fall related to alcohol. So it's easy to link why they're there with, this opportunity for treatment, but it's not that scary to talk about it in terms of stigma, because you're not accusing the patient of doing something illegal the way, sometimes people feel really uncomfortable talking about, opioid use disorder, which is so uncomfortable and so stigmatized to the patient. So I think in that way, these conversations are somewhat easier and easier to get your colleagues on board.
So most people are probably either working out or driving home on this podcast. And that means they've either entered that last stretch on the treadmill or they have just turned into their neighborhood. And you get one final word. What's the one last thing you want to leave our listeners with when it comes to treating alcohol use disorder, and the one real learning lesson you want them to walk away with from today's experience?
I mean, I would say you don't need a pathway, a protocol, or anything. Just start talking to patients about whether they've ever been prescribed anything or if they're interested. And you can write your first prescription without any other details. You can start it tomorrow, but the conversations are really easy and really the patients are grateful and eager to hear more about it. And I think as just a simple next step, that's the way to go.
Just do it. I agree completely. I think that's a shorter version of Jeanmarie's, but I think that is, just take the leap.
That's what emergency physicians are great at, right? Like historically, much of our practice has grown from being responsive to the patients that we see in front of us, trying out, testing new things. We're not always going to have a randomized clinical trial for every single thing we try. And so the important thing is to take that first step. Jeanmarie, thank you for joining us today. This was an amazing discussion. I learned a ton. This was not part of what I got when I was a resident. I am now convinced that we can take on alcohol use disorder in the emergency department, that there are a lot of pharmacologic options that are available, that even without perfect community resources, what we do in the ED really matters. And I think it's like you said, having a really passionate champion can help kick this off, but this is really something that can be part of each and every one of our jobs in the emergency department, because it's a patient we know we see every shift, and it's somebody whose health we can really impact. Thank you for making us all smarter. Hope to have you back on the Quality Podcast in the future.